Hello, everyone. This is Dr. Bishal Gyawali from Queen's University, Kingston, Canada, continuing with our series on the Skills Lab series on how to appraise a clinical trial publication well. And in last few videos, we have started to discuss on the methods section, and we touched briefly on surrogate endpoints. Surrogate endpoints is a pretty big topic. So today as well, we'll continue with the same. So first, uh, I wanted to say that surrogate endpoints is quite a big topic. There are lots of confusions about surrogate endpoints. There are several questions that people ask about surrogate endpoints. And in these videos, we are trying to answer those, but it may not be as comprehensive. So if you want to get a comprehensive understanding of almost all questions out there regarding surrogate endpoints in oncology, I highly recommend you to read this publication, which we have recently published, which is open access. But continuing with surrogate endpoints, we discussed in the last presentation about how to differentiate between prognostic and predictive surrogate endpoints. Today, let's talk about how we classify and define surrogate endpoints. We classify them in different ways. So one of those ways is surrogate endpoints in the setting of early cancer drug trials, as in neoadjuvant adjuvant setting trials, and then in the advanced setting trials. And within advanced setting, we have different types of surrogate endpoints, such as response rates, clinical response, partial response, and overall response rates, as well as progression-free survival. And these are usually defined on the basis of a criteria known as RECIST. RECIST stands for Response Evaluation Criteria in Solid Tumors, and that's classically what almost every clinical trial uses to define these surrogate endpoints in advanced setting. First, let's talk about what was the goal of REGIST criteria. Why was this developed in the first place? It was not developed to make therapeutic decisions. It was not intended for drug approvals. The whole idea about REGIST was to help clinical trials to define success or lack of success um, early on without the need to wait for overall survival. And the goal was to make those decisions from whether this drug should be tested in a phase 3 from a phase 2 and so on. The idea was not to use this for approval or therapeutic decisions. So you can read the REGIST publication in detail, but briefly, to classify under REGIST, you need a target lesion, and there are conditions on what can classify as a target lesion and what cannot. But disease progression or progression of disease (PD) is classically defined as at least 20% increase in the sum of maximum tumor diameters, with an absolute increase of at least 5 millimeter, or development of a new lesion that was not there before, or death of the patient. So any of these will classify as disease progression. So we classically keep talking about progressive disease as 20% increase in the size of the tumor. Complete response, as the name indicates, it's complete disappearance of all lesions. Partial response is shrinkage in the sum of maximum tumor diameters by at least 30%. And anything in between, that means the tumor size has decreased, but not by at least 30%. It has decreased by less than 30%, or the tumor size has increased, but not by more than 20%. It is less than 20%, is called stable disease. Anything in between disease progression and partial response is stable disease. And overall response rate, or sometimes people also call objective response rate, is complete response rate plus partial response rate. So the percentage of the patients who had any response is overall response rate. And we also measure the duration of response, which is the duration after achieving response until the tumor starts to grow again. There are also some other, what I call make believe meaningless endpoints. For example, people talk about clinical benefit rate, which is overall response rate plus stable disease rate. That means the idea is if the disease does not progress, then that's a clinical benefit. But these do not correlate with any meaningful endpoints. This is just make believe. This is meaningless endpoint. People should not focus on clinical benefit rate. Uh, Anyways, so why we're defining this is to see why these surrogate endpoints do not necessarily correlate with overall survival or quality of life. A, because These were not intended to be used as such. And B, the way we define them is quite arbitrary. As you can see, there is nothing magical that happens at 20% progression or 30% shrinkage of tumor. You can imagine that if a person has a disease progression of 18% versus 22%, that's not going to cause any meaningful difference. Whereas, a disease might grow by only 10%, but if it is at a sensitive location like intracranial, then it could lead to some symptoms. So not all disease progression events will be the same. So there is nothing magical happening at this 20%, 30% cutoffs, and therefore they do not correlate with clinical endpoints. Now let's talk about early cancer trial setting. In the neoadjuvant adjuvant setting, we have endpoints such as disease-free survival, invasive disease-free survival, event-free survival, metastasis-free survival, relapse-free survival, or recurrent-free survival, and pathological complete response. Pathological complete response deserves a special mention because it is used more as a prognostic marker. It is not reliable as a predictive marker. It is reliable as a prognostic marker. That means irrespective of how you achieve pathological complete response, you will have a good prognosis. But that does not necessarily mean that a drug that improves pathological complete response will improve survival. And event-free survival is basically disease-free survival, but in neoadjuvant setting. Of course, it's not feasible to go through definition of each and every endpoint here. But again, if you want to have a more comprehensive understanding, I refer you back to that publication where all these endpoints are defined. But another way of defining endpoints, it can also be response-based endpoints, such as the objective response, complete response, partial response, pathological complete response that we talked about, versus time to event endpoints. And this is important because they are measured in and analyzed in a different statistical way. So time to event endpoints are any endpoints that is measured in terms of the time it takes for the event to happen. So our overall survival, sorry, we are talking about surrogate endpoints. So disease-free survival, the progression-free survival, metastasis-free survival, all of these are time to event endpoints. So let's spend some time talking about response rates because it is getting more and more frequently used in clinical trials and also as a basis for approval. But it's a very weak surrogate. The correlation with overall survival is even weaker than progression-free survival. And the other interesting thing about response rate is there is no way to define success. As in, if we are measuring response rate in a phase 2 or a single arm trial, is a 30% response rate enough? Is 50% response rate enough? Is 20% response rate enough? In how many patients? In 50 patients, 40 patients? There is no way to define success here. And as I mentioned, this was not meant for approval or clinical use. This was meant for transitioning from phase 2 to phase 3. And in fact, we did a comprehensive study on response rate of placebo in randomized controlled trials of cancer drugs. And you'd expect that placebo would have a 0% response rate. But we were surprised to find that even placebo had 1% response rate. And complete response rate was, of course, 0 with placebo. But even placebo had a 1% response rate. And when you put that in context with uh, what we are approving nowadays, for example, this is 1% response rate overall, but there were some typical examples. For example, I'm showing this trial from renal cell carcinoma in which interferon, a drug, was compared with placebo. And in this particular case, placebo had a higher response than the drug. The response from the drug was 4.4%, and placebo had a 6.6% response rate. One more example from desmoid tumor, where placebo had an overall response rate of 20%. But you compare that with some of the drugs that we have approved on the basis of response rate, like 12% response rate in Checkmate 032 trial, 15% response rate in EZH 20221 trial, 70% response rate in Keynote 224. So these are not good enough response rates. But we are approving drugs on the basis of this very, very small response rate. So we need to be very careful. So I think that even if we were to rely on response rate, it has to be in the context of a randomized trial where we are comparing the response rate of the drug against the response rate of the comparator arm. Just relying on response rate in a single arm trial is very, very likely to give us false positive. And let's also talk about progression-free survival. We talked a lot on progression-free survival in our last lecture, but I'd also like to mention that there are some specific occasions where progression-free survival absolutely cannot be relied upon. For example, in later line therapy trials or in situations where the prognosis is so bad that survival events happen within a year. For example, if we're talking about second line, third line cholangiocarcinoma, pancreatic cancer trials, patients have a median survival of 6 to 8 months, and not even 6 months if we're talking about second, third line. In that situation, there is no sense to use progression-free survival because you can measure survival so quickly, and there is no point in having a drug that does not improve survival. So when the prognosis is very short, especially for later line therapy trials, PFS cannot be used absolutely. And for combination therapies, when we're combining drug A plus B versus drug A alone, of course, if we combine two drugs, it will extend progression compared to one drug alone. But the point to ask is combining upfront better than giving the same drug sequentially? And only overall survival can answer that. And for maintenance therapies are situations where we continue on a treatment for a long term, where the standard of care actually is to do no treatment. So if you're giving an active drug instead of not giving a drug, of course you'll extend progression. But does that lead to improved survival outcomes? And should we subject all our patients for that extended duration of treatment? So in these situations, PFS cannot absolutely be relied upon. Let's spend some time about adjuvant setting as well, because in adjuvant setting, I find it even more trickier to rely on surrogate endpoints such as DFS as opposed to overall survival, because in adjuvant setting, by definition, we're treating all the patients, some of whom may not need treatment and some of whom may not benefit from treatment. But 100% of the patients will get toxicities. In this particular example, in the Kaplan-Meier graph that you can see, a 2-year landmark, there are 22% of the patients who have relapsed or died even after getting the drug. And there are 68% of the patients who did not relapse even if they only received placebo. So we are benefiting only that small margin of patients, that 11% of patients who benefited from getting the drug. And again, in this situation, we should also ask whether the patients who got placebo in this trial actually received the drug when they relapsed and how it affected overall survival. So especially for adjuvant setting, we had this publication where we advocate to use the approach of 3 E's: evidence, ethics, and economics, to decide whether or not treating all the patients upfront on the basis of DFS or surrogate endpoints is better than uh, treating only the patients who relapse at the time of relapse. That ends our video for today. In the next video, we'll continue on some additional points about surrogate endpoints. Thank you.